Time is yours, Dr. Epstein. Sorry for the bit of trouble.
No problem. Should we start the lecture?
Yes, please, sir.
Okay, hopefully everyone can see this.
Yes.
So I'll be discussing evaluation of prostate cancer and atypical on needle biopsy and a couple of mimickers as well. For some reason, slides are not advancing.
There.
Okay. So the difficulty in underdiagnosing prostate cancer is there's often very limited tissue on needle biopsy. It cores only a millimeter or so in width. Often there's very limited cancer on needle biopsy. And in contrast to many other cancers in the body, histologic findings are often very subtle. So what I'll emphasize today is that the diagnosis of prostate cancer should be done using a systematic approach based on specific architectural, cytological, and ancillary features. With the exception of a few findings that by themselves are specific for cancer, the diagnosis of prostate cancer is typically based on a constellation of features. So what I'll discuss and show in various slides is some of the features that favor the diagnosis of prostate cancer. First, starting with an abnormal architectural pattern. We then turn our attention to the nuclei, looking for enlargement, hyperchromasia, prominent nucleoli, mitotic and apoptotic figures. Then the cytoplasm, which is often darker, and then intraluminal contents, whether it's blue mucinous secretions, pink amorphous secretions, or crystalloids. So the first architectural feature that one should, at scanning magnification, go down and look more carefully are presence of crowded glands. As I'll emphasize, not all crowded glands in the prostate are cancer, but nonetheless, when you see crowded glands, it's something you want to focus more carefully on. I scan my prostate biopsies at 4x using the 4x lens, but again, some of you may feel more comfortable at somewhat higher magnification using a 10x. So here we can see that there is a crowded focus of glands here in the middle. And then what one you would ideally like to do is find glands that are benign in the adjacent areas, such as here on the left, and compare them to the glands that are crowded and that architecturally you're suspicious could be cancer. And here we can see, compared to the benign glands, that these glands on the left have a large nuclei and some nucleoli.
Dr. Epstein, I'm sorry.
Yes.
I think your slides are not advancing. I think I'm apologizing for cutting you off. We're still stuck, in difficulty in underdiagnosing
So
prostate
you don't
cancer.
see this moving?
Yeah, not yet. I think we're not in
Okay.
presenter view. Yeah.
Let's start again.
We got the introduction. I'm sorry about that.
Yeah, 1 second. You don't see it moving now?
Yeah, I think no, it's not moving. Yeah.
Okay, let's just start from the beginning. I'm not sure why.
There,
Okay, so
it moved now. Yeah.
let me just start the thing again. Hold on.
No problem. No problem.
You see the move now?
Currently showing all the slides though, not one particular slide.
They're not presenting. That's bizarre.
Yeah. Yeah.
1 second. Let me close out all the other ones that I have, and we'll start from the beginning.
No problem.
Okay, so let's do this. Okay, can you see the move now? Let me also just stop share screening and start it all over again. I'm just going to come into the Zoom all over again.
Okay.
Do you see them move now? No. Share. What's going on? Okay.
Are you on? Oh, sorry.
Can you see them move now? Just 1 sec. Jeepers, they're frozen. How about now?
When they're frozen, for some reason they're frozen just on this screen, showing all
Yeah.
the multiple slides. Yeah.
Jeepers, I can see all of them. Oh, jeepers.
Do you want to send it to us? Maybe we could share it for you.
Hold on now. Let me just try one more time.
Sure.
Okay, so hold on. Maybe I have to move it to this screen. Hold on. Let me just move it to this screen. Um, be discussing is features favoring the diagnosis of prostate cancer, starting with an abnormal architectural pattern, nuclear enlargement, hyperchromasia, prominent nucleoli, mitotic and apoptotic figures, amphiphilic cytoplasm, blue mucinous secretions, pink amorphous secretions, and crystalloids. So what you first want to look at is architecturally, you look for certain features that are suspicious for prostate cancer at low magnification, whether at 4x or 10x. And so in this case, the features that catch my attention are the focus of crowded glands that we see here in the middle. Again, not all crowded glands are cancer. As I'll show you, there are some mimickers of crowded glands that are just as crowded as cancer. But nonetheless, we want to look at these more carefully. And then you want to compare them to glands that you can identify as benign. So on the left is a gland that's benign. On the right is one of those glands from that crowded focus. And we can see some enlarged nuclei and occasional prominent nucleoli. And then if we look further in that focus, we can see again multiple nucleoli. Now, what I would like to emphasize on this particular slide is the problem with looking for basal cells on the H&E. So, for example, these dark nuclei here, could be basal cells, but end up being just fibroblasts that are closely opposed to the neoplastic glands. So for the most part, it's almost impossible to identify basal cells on the H&E, and I'll discuss a little later on the use of special stains that can help in this regard. The other architectural feature that is suspicious for cancer is the presence of small glands. Again, not all small glands are cancer, but nonetheless, many cancers are composed of small glands. So here we see a focus of small glands, again, going to higher power. In the lower right is a benign gland, and on the left is a focus that we want to compare to those small crowded glands. We can see some nuclear enlargement, some nucleoli. We see a mitotic figure and these dense eosinophilic geometrically shaped structures, which are crystalloids. As I'll talk about, crystalloids are not specific for cancer, but more commonly found in cancer than in benign glands. So here we have multiple features favoring the diagnosis of cancer, nothing against the diagnosis of cancer, and we can make a definitive diagnosis of a limited focus of Gleason score 3 + 3 = 6. I mentioned apoptotic bodies. Apoptotic bodies are actually more common than in mitotic figures. So in this study, we found mitotic figures only in about 13% of cancers versus apoptotic bodies in almost a third or a little bit over a third of cancers. Now, it turns out where the nucleoli are, whether they're up against the nuclear membrane or in the center, and the number of nucleoli don't help to distinguish between benign mimickers and cancer. The other architectural pattern that is actually more diagnostic of cancer is an infiltrative growth pattern. And in order to diagnose an infiltrated growth pattern, you want to see the neoplastic glands on both sides of benign glands. So here we can see where these arrows are pointing, these glands with a little bit darker cytoplasm infiltrating between the benign glands, and that is diagnostic of prostate cancer. Another feature that's helpful in the diagnosis of prostate cancer is a linear array of glands. So here we can see this forming this row of glands in between benign glands. That's not something you would see in any kind of a benign glandular process, also diagnostic of cancer. Now, there are some cases where you do not find any of these architectural growth patterns, but you just find glands that are crowded. But then when you go to higher power, there's virtually no cytologic atypia. So all you have is a crowded glandular pattern. In these cases, you have to be extremely careful in diagnosing cancer because, as I'll show you, some mimickers of prostate cancer can be composed of very crowded glands with no cytologic atypia. And the only way I would feel comfortable diagnosing cancer in this setting would be that if you can show with the use of basal cell stains and racemase, but more importantly, the basal cell stains, that all those glands that are crowded are entirely negative for basal cells. No patchy staining anywhere else. But you have to be extremely careful diagnosing cancer solely based on crowded glands in the absence of any other of the cytological features that I mentioned are more common in cancer than benign. Now, if we turn to nuclear features, we mentioned nucleoli, apoptosis, mitotic figures, but nuclear hyperchromasia in large dark nuclei is also very useful to diagnosing cancer. So even in the absence of prominent nucleoli, If the nuclei look dark and enlarged, that can help diagnose cancer. Turning our attention to the cytoplasm, most benign glands have a very pale, lightly eosinophilic cytoplasm. Some, not all cancers, have more amphiphilic, darker cytoplasm, as we see here. That's a helpful feature to diagnose cancer. Here we see glands, the benign gland in the upper right. These glands have darker cytoplasm. They also have straight luminal border. When you start seeing larger cancer glands that have, they will have often a straight luminal border. For example, if you look at this larger benign gland in the upper right, it has these luminal undulations ruffling to the cytoplasm. So this straight luminal border helps to diagnose cancer. We also see that many of these neoplastic glands have blue mucinous secretions, another feature more commonly in cancer than benign. Another feature more common in cancer than benign are these dense eosinophilic intraluminal secretions, also, again, straight luminal borders. So what you want to do is look for as many atypical features that I've just mentioned, and the more atypical features you have, the more confident you can diagnose cancer in a limited focus. So here we see a gland with an atypical, with a mitotic figure, dense pink secretions, blue mucinous secretions, crystalloids. So again, the more features present, the more likely that this is cancer, not benign. Now, you can diagnose very limited amount of cancer on a biopsy, especially when it has an infiltrated growth pattern. So here we see benign gland, and then in the middle, these more amphiphilic glands that are tucked tightly in between benign glands. High-grade prostatic intraepithelial neoplasia, which can have many of the cytological features of cancer, including dark cytoplasm, nuclear atypia, et cetera, has to be an architecturally benign gland. So it would be evenly spaced between other benign glands. So the fact that this atypical gland is tightly packed in between two benign glands, it's in an abnormal place where one would not expect to see benign glands. Consequently, this cannot be high-grade PIN. So this has to be cancer. And then if you do the stain for PIN high molecular weight cytokeratin and racemase, you can see it helps helps to diagnose cancer given the absence of basal cells and the strong racemase. Now, as I mentioned at the onset of the lecture, there are a few features that by themselves are diagnostic of prostate cancer. One is perineural invasion, another is glomerulations, another mucinous fibroplasia, and extravasated mucin. So sometimes perineural invasion, which is probably the most common of all these features that are pathognomonic of prostate cancer that I mentioned, can mimic a benign gland at low power because it can encircle a nerve and then open up to form little larger gland around the outside that if you're not careful, you might just overlook as a benign gland with maybe a little papillary infolding. So you want to carefully look at a gland that just has papillary infolding, but not a fibrovascular core. If we go to higher power here, we can see this nerve surrounded by this gland, and that is diagnostic of prostate cancer. Now, you have to be careful. You can see perineural and intraneural involvement by benign glands. Here we see totally benign glands, pale cytoplasm, benign cytology, atrophic appearance, and they're indenting a nuclei, indenting a nerve. That is still consistent with benign glands indenting a nerve. Now, sometimes we'll see overt cancer indenting a nerve, and in the setting of overt cancer indenting a nerve, we do call that perineural invasion by prostate cancer. But in this case, this is perineural indentation by benign glands. More kind of complexity and more worrisome is when you see fibrosis, this very delicate, loose fibroplasia, that's only seen in prostate cancer, never in benign glands. Mucin extravasation, where we see extracellular mucin, is also something that we never see associated with benign prostate glands. We can see it with, for example, various mimickers in bladder cancer, but not in prostate cancer. So the fact that we see these glands with extracellular mucin, again, this has to be prostate cancer. Glomerulations is another feature, pathognomonic of prostate cancer. It's Gleason pattern 4, where we see a cribriform process protruding into a neoplastic gland, but not transluminal like we typically think of a cribriform structure. But any little glomeruloid structure, if you see it, again, that has to be prostate cancer. Now, I'm going to turn to some cancers that can mimic benign glandular proliferations. That's pseudohyperplastic prostate cancer, foamy gland prostate cancer, and atrophic prostate cancer. So pseudohyperplastic prostate cancer architecturally resembles benign glands. And these patterns include they have papillary infolding, branching glands, or large dilated glands, features that we typically associate more with a benign glandular process. So here we see a needle biopsy. And at first, what we want to say at low power is that there is a focus of crowded glands on the right, compared to on the left, these are glands that have nice infolding, separated by stroma, so more overtly benign here on the left. Now, at low power, this is not diagnostic of prostate cancer, but we would want to look at it at higher power and see, what are the other features associated with this more crowded glandular focus. So one of the things we notice is a feature I've talked about already, that some of these larger glands have a very sharp, straight luminal border. And that is something that favors prostate cancer. Now we see some of the other larger glands have infolding, which is more a feature of benign glands. So we're getting mixed kind of messages here. Next, we want to go to higher power. And when we go to higher power, we can see many prominent nucleoli. So that is highly suspicious for prostate cancer. And then we would want to do a confirmatory basal cell stain. And what you want to do when you do the basal cell stain is first identify on the H&E what are the glands that you're highly suspicious for cancer. So those were these on the right. And then we say, what are the glands that we thought on the H&E were benign, i.e. on the left. And what you would like to see is all the glands that you thought are suspicious for cancer are entirely negative for basal cells, and the glands that you thought are benign are positive. So in this case, all of that is true, and so we can diagnose this as pseudohyperplastic prostate cancer. If there was any patchy staining here on the glands on the right, I wouldn't call it cancer, because that, for example, could be high-grade PIN. Foamy gland cancer architecturally looks like cancer, but the reason why pathologists have a lot of difficulty is very bland cytology. So here we see a crowded focus. They often have these dense pink secretions, which I've talked about. On the right upper is a benign gland in comparison. So cytologically, they look very similar to the crowded glands, but they don't have that dense pink secretion. And then when you go to higher power on foamy gland, again, the nuclei are extremely monotonous and bland, and that's why pathologists are very uncomfortable calling cancer. But they have this huge amounts of cytoplasm relative to the nuclei, something that's beyond what you see in normal cytoplasm. And again, in a case like this, you would probably verify it with the basal cell stains. Now, prostate cancer with atrophic features can be seen de novo or in patients with hormonal therapy, but most of the time when you see it, there is no history of anti-androgen therapy. How do you diagnose atrophic cancer and distinguish it from benign atrophy? Either by an infiltrative growth pattern, huge nucleoli, or sometimes by the presence of just usual non-atrophic cancer. So as I mentioned before, to call something a truly infiltrative growth pattern, what you want to see it is that the glands are going in and amongst benign glands on both sides of benign glands. So here we see very atrophic glands, a benign gland on the kind of in the upper left, a benign gland on the lower right, but these atrophic glands are going all up and down between these benign glands. And when you go to higher power on these atrophic glands, small glands, they really could be indistinguishable from benign atrophy, no cytologic atypia. So the only way that we can diagnose these are by the architectural pattern. And in a case like this, I would do a confirmatory stain for basal cells. Here showing all these infiltrative small atrophic glands are entirely negative for basal cells, diagnostic of cancer. Now, the other way that you can diagnose atrophic cancer, as I mentioned, is if you have huge nuclei. You can see small nuclei in benign atrophy, but these large cherry red nuclei are not something you would see in a benign glandular process. So even though these glands are very atrophic, it is diagnostic of prostate cancer. Now, so far, I've been emphasizing features favoring the diagnosis of cancer. There are features against the diagnosis of prostate cancer as well. So again, you have to be careful when you see atrophic cytoplasm. That could be atrophy. I'll talk about partial atrophy as a mimicker of prostate cancer. You have to be careful when very crowded small glands that architecturally look like cancer merge in with glands that are more overtly benign, where you have to rule out adenosis. I'll talk about that as well. Corpora malacia are more common in cancer than benign. You can see them in benign gland, but nonetheless, you should be cautious calling cancer in the presence of corpora malacia. Inflammation, I'll talk about that as well, can mimic, causing both the architectural and cytological features mimicking cancer. And then you have to be careful when you have adjacent pin as well. So I get to cover all the mimickers of cancer, but let me cover some of the two most common ones. One is adenosis. It's also been called adenomatous hyperplasia or atypical adenomatous hyperplasia. So this is a case of adenosis on needle biopsy. So on just scanning magnification, if you looked at this, you would probably think to look more carefully at this. So if we look at kind of the lower left, these glands look small and crowded, no infolding, that could definitely be cancer. But if we look at the upper right, you can see that some of these glands have infolding, they're larger, little papillary projections. That's unusual in cancer. So again, we're getting kind of mixed signals. So let's look at a little higher power. If we look at the area in the upper right, you can see that some of these glands have infolding, some of them have leaching glands. That's something that would be seen in pseudohyperplastic prostate cancer, but not in usual prostate cancer. And then when we go to higher power, here's a gland that looks more benign. It has infolding. We see crowded glands that by themselves would be suspicious for cancer, but all of these glands have very benign cytology, no cytologic atypia, in contrast to the cytologic atypia you need to see in pseudohyperplastic prostate cancer. And then when we do a stain for P63 in this case, you can see that there are scattered basal cells. Now, you have to be careful with adenosis because not every gland will show staining. Here we see several glands that are negative, and the staining that you see will often be very patchy, meaning within a given gland, you may only see 1 or 2 cells that are positive. So consequently, you have to be very careful calling cancer in the setting of very benign cytology, because it could be adenosis. And even if there's just 1 or 2 cells that are patchy, you want to back off and not call it cancer because that still could be adenosis. Now, probably the most common mimicker that I see in my consult practice that is particularly difficult is partial atrophy. So partial atrophy will consist of glands that look pale at low to scanning medium magnification. They will look crowded, so they'll stand out as being different than the adjacent benign glands. But the key feature for partial atrophy is that the glands are atrophic, meaning that if you look at them at a little higher power, the nuclei go almost up to the top of the cell. So there's very little apical cytoplasm. The other feature that you see in partial atrophy is the nuclei look very bland. And there's also, and this is subtle, but it's important, is that the cytoplasm has a ruffling to the luminal border. In contrast to the very sharp, straight, kind of razor edge of cancer glands that I talked about at the onset of this lecture. With partial atrophy, it's the opposite. If it's a very ragged ruffling of luminal border. Now, you have to also be careful both with partial atrophy and adenosis. Because you're dealing with a small glandular process, you can get tangential sections, even giving rise to what appear to be poorly formed glands or even cords of cells. But again, that's just an artifact of tangential section off these small glands. Now, similar with adenosis, partial atrophy has very patchy and focal basal cell staining. Again, Within a given gland, you may only see 1 or 2 cells positive, and not every gland will show staining. So you can see a cluster of glands that will be negative for basal cells. And partial atrophy and adenosis can also be positive with racemase, which is a more common a feature of cancer. So you can get staining that can look almost identical to cancer with even a negative basal cell staining and positive racemase in a small focus, and it still could be partial atrophy or adenosis. So you really do have to rely on the H&E and use the ancillary staining only as an adjunct. So let's turn our attention a little bit to basal cell markers. How do I use them? If I see something that's atypical, I'm favoring cancer, and the stains are negative for basal cells, that gives me one additional feature that's confirmatory, and I can diagnose cancer. But let's say something was atypical and I favored it was benign. Even if the staining is negative, I won't go all the way to cancer. I'll call that atypical. If it's benign, on the H&E, I don't do staining, but I often receive, for example, consults that have staining associated with them that they've done on the outside. And I look at the H&E and I say, this is partial atrophy, or I'm comfortable. It's just another benign gland that sometimes is negative. I'll still call it benign. So again, basal cell markers should be used in conjunction with the H&E, and the H&E is the most important, not the basal cell markers. So here's a case that I think is appropriate to use basal cell markers. So again, on a difficult case, we can see there's a crowded focus that catches our attention at low power. But what you want to do is first find the glands you benign. So, here's a large gland in the light. Low power, not that atypical. But when we go to higher power, we can see all these glands are negative. They're tightly packed in between the benign glands. So that, along with, some nucleoli in some of these smaller glands, even though they're not extremely prominent, would be diagnostic of a small focus of prostate cancer. Now, the pitfalls with basal cell markers is even entirely benign glands sometimes won't stain for basal cells. But more problematically is some of the mimickers of cancer, like adenosis, partial atrophy, and high-grade Penh, can have some negative staining glands. Cancer glands and cancer cells can also occasionally stain non-specifically. And by non-specifically, I mean not in a basal cell distribution. And I'll show an example of that. And then extremely rarely, cancer can aberrantly express basal cells. So here's a case, another pitfall with basal cell markers is cancers can aberrantly express P63, and we've written several studies on that. So here's a case of where we see cancer, all the cancer is negative for high molecular weight cytokeratin. But when we look at the combination of high molecular weight P63 cocktail, you can see the benign glands here both show nuclear and cytoplasmic staining. You see the little tails of staining with the high molecular weight keratin. But with the cancer glands, you can see they're only showing the P63 and not the high molecular weight. So you have to be aware that, again, rarely you can see cancers with aberrant P63 staining. When you do P63 by itself, they become a little bit more obvious. If you use a cocktail with high molecular weight and P63, you have to pick up that in contrast to the benign glands, the cancer is only expressing nuclear staining and no cytoplasmic staining. And sometimes in that case, it's helpful just to do a high molecular weight by itself, which would more clearly show that these glands are negative. Now, here's a case that's obvious, or it's pretty obvious. It's cancer. The benign glands are in the lower right, pale staining glands, no cytologic atypia. These glands have amphiphilic cytoplasm. There were some nucleoli. But when we look here, the high molecular weight cytokeratin is staining some of the glands. Now, in contrast to the benign glands, which are staining basal cells in a flattened distribution beneath overlying negative secretory cells, here they're staining the cancer cells. They're not staining in a flattened basal cell distribution. And if you look and do a separate P63 with these same glands, we see none of the staining. So you can see some non-specific staining of cancer with high molecular weight cytokeratin, and you have to still be able to diagnose cancer in that setting. In terms of racemase, racemase more commonly stains prostate cancer than benign glands. How do I use it? Here we see a small focus of atypical glands a little bit more amphiphilic cytoplasm. They're more crowded. You go to higher power, these nuclei are enlarged, some nucleoli compared to the benign glands. So I would, be extremely suspicious that this is cancer. When we do the high molecular weight keratin, P63 and racemase in a PIN4 cocktail, we see these glands are negative for basal cells and light up with racemase. So all of that together can help you to make a diagnosis of cancer, which you might otherwise not feel entirely comfortable doing. Now, there are pitfalls with racemase. It stables high-grade PIN. Sometimes even benign glands will stain with racemase. And then the two mimickers that I talked about, partial atrophy and adenosis, can also stain with racemase. So again, you have to be careful in those settings. Also, it's not you do have some false negatives. Up to 20% of small foci of cancer may be negative for racemase. So again, you still have to diagnose cancer in that setting. I mentioned some of the more difficult diagnosis types of prostate cancer, subtypes, foamy gland cancer, atrophic prostate cancer, pseudohyperplastic cancer. Those cancers tend to not stain with racemase as much. So anywhere from 25 to 35% of these will be negative with racemase. So let me go into explain finally to discuss atypical needle biopsies. What are the settings where you can't be definitive and diagnose prostate cancer? First of all, I don't use the term atypical hyperplasia. It's a very vague term. I don't use the term atypical small acinar proliferation. It's not as objectionable to atypical hyperplasia. The only pitfall with this is some clinicians think it's a very specific entity, where in fact, it's not really a specific entity. It's more of a status of uncertainty that we're not sure it's cancer. So what I tend to do is be descriptive. So an atypical sign-out will be prostate with small focus of atypical glands. And then I put in a note, although these findings are atypical and suspicious for adenocarcinoma, so that's very clear to the clinician, I state there is insufficient cytologic and/or architectural atypia to establish a definitive diagnosis. And then I say follow-up was warranted with either serum or urine tests, imaging, and in some cases, repeat biopsies with relatively increased sampling of the atypical site may be recommended. Not all clinicians will do a repeat biopsy if you call something atypical, given that many men, even if they find small focus of low-grade cancer, might be just followed with active surveillance. So I leave it up to the clinicians whether they want to do a repeat biopsy. So what about this focus? Again, find the glands you know are benign first. So on the lower right is more typical benign glands. Here in the middle, these glands are crowded. There are cytologically really not much atypia. Many of these glands are atrophic. There are some crystalloids, but again, that's not specific for cancer. So on the H&E, I would not feel comfortable calling this cancer. On the stains, these are negative for the basal cell markers. But I still probably wouldn't feel entirely comfortable calling cancer because they're so atrophic. Could be partial atrophy, and as I mentioned, partial atrophy can be negative for basal cell markers. Here's another case that's, again, a benign gland here. There's another benign gland upper right with corpora malacia. See this crowded glands, could be adenosis. Some of these glands have infolding. Some of them are atrophic. Could be cancer too. We go to higher power. There are scattered basal cells. So I would definitely not call this cancer. I probably wouldn't be definitive in calling this adenosis. I'd probably say typical favor adenosis, but can't totally exclude, low-grade cancer. But again, definitively would not call this cancer. And then you have to be very careful calling cancer when it's on the edge of the core and you see just a few glands, even if they're negative for basal cells, because you don't know what's on the other edge, and you don't know, that there could be adenosis adjacent to it. So even though these glands have straight luminal borders, some dense secretions, I would call that atypical suspicious for cancer. Here's a case where we see some neutrophils in the lumen. Even a few neutrophils would make me back off from calling cancer because it can cause cytologic atypia. It can also cause even crowded glands. And then sometimes we have something that really does look like cancer, but it's literally just maybe one gland. And unless that gland is like tightly packed in between a benign gland, I cannot exclude that this could be high-grade PIN coming in from another plane of section. And so even with this one gland, even if that one gland is negative for basal cells, positive for racemase, I would call that atypical, highly suspicious for cancer. Again, if that one gland was tightly packed in between these benign glands, I might be able to call it cancer, but not when it's not in that setting. And then here it shows why you have to be careful on the edge of the prostate needle. So on this, this looks suspicious for cancer. The glands are amphiphilic. There's some nuclear enlargement, some small nucleoli. When you do the basal cells, they're positive for racemase, but also patchy for basal cells. So again, there could be high-grade pin off to the edge that we're not seeing, and these could be outpouchings off of high-grade pin. So be very cautious calling cancer on the edge, just on a couple glands. So in summary, with the exception of a few findings, the diagnosis of prostate cancer should be based not on any single feature, but a constellation of features. You weigh the features favoring cancer against the features that are against a diagnosis of cancer. And hopefully what I've been able to illustrate today is that even in the setting of a few atypical glands, if you have multiple features or several features favoring cancer, nothing arguing against cancer, you can make a definitive diagnosis of cancer on a relatively limited focus. And with that, I'll end. And again, most of what I've talked about is in my book on biopsy interpretation of the prostate. Thank you very much.
Thank you so much, Dr. Epstein. We'll have a few minutes for a few questions. We have a question here coming from one of our members. He's asking, among AMCAR, P63, and high molecular weight CK, do we have to use every stain, or can we just use one basal cell marker if I would think he's thinking about financial constraints in certain instances?
Right. So there are some cocktails that come packaged all together, but in a sense, most of the time, high molecular weight cytokeratin and P63 do the same thing. They're both highlighting basal cells. 95% of the case, they're going to stain exactly the same. So for the most part, you can get by with one or the other, not both. The only thing you have to be careful, if let's say, for example, you use P63 by itself, be careful about P63 aberrant prostate cancers. If you use high molecular weight keratin by itself, be careful about the non-specific staining of basal cells with high molecular weight keratin. But again, both situations occur in a minority of cases. So again, you can get by without them. You can get by without racemase and just doing a basal cell stain, and I know some labs do that even here in the United States. The advantage of the racemase, there's pitfalls and advantages. Pitfalls I showed you, it's not always specific or sensitive. The advantage is it's just one more feature that if you have this tiny focus, it's negative for basal cell and it lights up with racemase, and all the benign glands around it are negative for racemase. It's just one more feature that gives you that more helpful feature to make that diagnosis of cancer. But it's not 100% essential, and most of the time you can get by without it.
Thank you for that. I do have a question. I know that you still call, how often do you call atypical in your practice? I know it's different from one practice to another, but is there a particular percentage that you feel comfortable that the total number of biopsies that you get are atypical? And number two, you still call something atypical even after your stains, for example, after doing PIN 4?
Ends up being probably about 5% or so are atypical. What's more common, it's often common in a case with definitive cancer that you will have other areas that are atypical. But you will have definitive cancer somewhere in that case. And whether you work up those atypical foci or not is not so critical. But in terms of atypical being the worst finding in the entire case, that's, again, about 5% of the time. So somebody asked, let's see, there was a question. Let me see. How much confidence do you consider when you see macronucleoli? Are they alone diagnostic of cancer? So the only time you can, so I would say they're not entirely diagnostic of cancer by themselves. The situations where you can see huge nucleoli that are not cancer, basal cell hyperplasia can have very prominent nucleoli, but there's multi-layering of the nuclei. And then high-grade PIN cytologically is indistinguishable from cancer, just like any other in situ versus invasive cancer. And so the only way you can differentiate high-grade PIN versus invasive cancer is not based on cytology, but based on architecture. Sometimes confirmatory if you have high-grade pain with a limited number of atypical glands next to it, then you need to do the basal cell stains and show that you have a sizable number of atypical glands that are all negative for basal cells. But you don't see the huge, you are right in the sense that you don't see huge nuclei in adenosis or partial atrophy, for example, or other types of atrophy.
Thank you. Any other questions?
The question is, I read in your book, you should make a mental balance sheet, right? So that's exactly right. Basically, when I look at a case, it's all done very rapidly, but I say, what are the features in this case that are favoring cancer on one side? Are there any features kind of arguing against the diagnosis of cancer? If everything favors cancer, nothing against, 99% of the time, I'll make a definitive diagnosis of cancer. But if there's even just something that's against cancer, corpora malacia, infolding, bland cytology, those are often the cases where I'm going to back off, call it atypical, or do stains and see if that can be confirmatory. So my threshold for cancer, some people have asked, do you need a specific number of glands to diagnose cancer? Some people say 3 glands, 5 glands, 10 glands. So I would say I don't specifically give myself a threshold for how many atypical glands I need to diagnose cancer. What I do say is, in general, that the more kind of atypical features that you have, of all the features that I've talked about, nucleoli, cytoplasm, interluminal features, architecture, the more atypical features you have, the more you can diagnose cancer on a very limited focus. When you have a limited focus of just a few glands and you have only one abnormal feature, maybe nuclear enlargement, those are the kind of cases that typically I won't call cancer. But it also just, in terms of the limited number of cancer, and how can you call cancer on 3 glands, 4 glands, 2 glands, I would say where those glands are is probably the most important. As I mentioned, if those glands are just in the middle of the core, I'm very careful. I wouldn't call cancer just on a couple glands because that could be pin coming in from another plane of section. If they're on the edge of the core, typically I'm not going to call cancer on just a couple glands because, again, I don't know what's around it. But if I see a typical gland tightly packed in between 2 benign glands where you wouldn't expect to see any mimickers, pin couldn't be that, that's the setting where I typically might call cancer on just literally a couple glands. Are there still instances of very low risk undergoing radical prostatectomy in the United States? Yeah, so it's changing, but it still happens. There was recently a very large study of tens of thousands of patients that showed, maybe 10% of radical prostatectomies are still Gleason 6, and they had Gleason 6 on biopsy or grade group 1 on biopsy. So it is happening, but that number is decreasing significantly over time. What that study also showed is that the men who underwent radical prostatectomy with a grade group 1 or a Gleason 6 tended to have some other atypical feature, meaning a very high PSA level, so that it was worrisome that might have been higher grade cancer elsewhere, multiple cores with Gleason 6, where, again, there's a higher risk that there may be unsampled higher grade cancer. But if you just have a limited Gleason 6, let's say on one core, most of the time, nowadays men are undergoing active surveillance. Question, do you still include the whole prostate for radical sampling? I would say that's not necessary. What's more important is to have a systematic sampling approach to the radical prostatectomy. So what you want to do is put through either the entire peripheral zone and then just a few random sections of the anterior prostate as well as the margins. 85% of prostate cancers are in the peripheral zone. So you'll identify 85% with your sampling of the posterior part of the prostate. You do want to put through just a couple sections of the transition zone, the anterior, because 15% of the time, the major cancer will be in the anterior. If you do a partial sampling technique and you see a lot of cancer on those couple anterior sections, then you want to go back and put through the rest of the prostate to sample the anterior. But most of the time, you can get by sampling just the posterior part of the prostate, couple in the anterior transition zone, and then your margins. How often do I see wispy blue mucin? I would say a lot depends on the person's H&E stainings. I see some H&E staining where that's more prevalent, and I see a lot of the cancers have that blue mucin staining. And for whatever reason, some people's H&E staining, you just don't see as much of that blue mucin. When it's present, it's a very helpful feature, but again, a lot of cancers, you may not see that blue mucin. Yeah, so we are almost the minimum standard nowadays. For myself, if I were undergoing a prostate biopsy, I would want to have a multiparametric MRI to look to see if there's an index lesion or index lesions and sample those as well. Multiparametric MRI has shown that it highlights the higher grade cancer, finds some cancers that systematic biopsy won't. But there are some times when the MRI will miss cancers and the random biopsies will find it. So both are necessary. But definitely, I would say a 12-core biopsy would be, for me, the minimum sampling. In terms of mapping out the radical prostatectomy, I think you typically should map it out because, for example, if you have a cancer in the right, 3 + 3 = 6, another cancer on the left, 4 + 4. If you didn't map it out, you might call that a 3 + 4 or 4 + 3. But in fact, the prognosis is based on the 4 + 4. So by mapping it out, you're able to see if there's multifocal separate cancers and give each separate cancer a different grade. And the highest grade nodule, not the highest grade adding all the cancer together, but the highest grade nodule is what's going to determine prognosis and potentially adjuvant therapy after the radical prostatectomy. Okay, I think I've been told that's the last question, but again, I'll be free to answer any questions that you submit by email, and I can post them on the website.
Thank you so much, Dr. Epstein, as always. It's good to see you and everybody. I hopefully learned a lot. Thank you so much.
That's been my pleasure. Thank you for inviting me.
Okay, thank you. We will now move on to the next part of the program, and this will be a case presentation from one of our founding members. May I ask for an introduction? Thank you so much for the introduction. May I call now Dr. Jerasit, or as we call him, Dr. Nick, to present this case. The time is yours, Dr. Nick.
Oops, I was muted. Can you hear me? Yeah, of course.
Yes.
Yeah, it's working.
Your audio is okay now.
All right, share my screen. I have only one screen, so no problem, right?
We're waiting on it.
It's all good?
There. Yeah, it's good now. Just need to
All right.
full screen.
So good morning. I mean, good evening. Good evening, my colleagues and friends from across Southeast Asia. And good morning, good afternoon, or good evening, depending on where you are, to everyone joining us from beyond the region. It's a pleasure and an honor to be with you all today. And big thanks to SEAUPS for inviting me to share an interesting case tonight. And before I begin, I would like to acknowledge a few people. Dr. Tirapong, the award good for my former resident who sent me this case, my mentor, Dr. Mimickers, for his blessing on the diagnosis, and Ms. Surinapa, my technician, who scanned the slides and helped me put together these beautiful images to share with you. With that, let's get started. My case, the patient is a 46-year-old man without any underlying disease, and he was found to have a high PSA incidentally on his routine checkup. Initially, it was in the 40s, and over 2 years, it rose to 131.7. And then he decided, yeah, it's about time to see a doctor. So he went to see a urologist. So did a rectal exam, and his prostate was enlarged, was estimated to be more than 40 grams, and there was a hard nodule in the right lobe. So the urologist suspected that the patient has prostate cancer, at least clinical stage 2B. So he did a random biopsy. So 6 from the left and 6 from the right. And about 8 of 12 cores showed essentially the same findings. And here's a representation of what the biopsy looked like. Okay, let me zoom in a little bit. So at my first glance, I looked at it like briefly, and looked kind of benign to me. That was my initial impression. So I just called my resident and told him that, yeah, look, they're benign. And he said, really? I think that, don't you think the stromal cells look kind of weird? And then I went back and looked again, and I started seeing that the stroma is littered with these cells with hyperchromatic nuclei. And yeah, he was right. I missed it. I was too focused on looking at the glandular component, which is yeah, most of the times they're going to be prostate cancer, right? But this time it's just these little pleomorphic cells, and if you go to higher power, you start to see them quite clearly that they are these pleomorphic cells. They are in the stroma here, some more, even here, right? So it's a spindle cell lesion of the prostate, and there are three broad categories of differential diagnosis that you have to consider when you see spindle cell lesions. So the first group are lesions that are unique to the prostate. The second group are the lesions that are not unique to the prostate, and the third group is secondary tumors involving the prostate. So in the first group, that includes sclerosing adenosis, stromal hyperplasia, stromal tumor of uncertain malignant potential, or STUMP, prostatic stromal sarcoma, PSS, and the sarcomatoid subtype of prostatic adenocarcinoma. All these can have like spindle cell. Lesions that are not unique to the prostate are these smooth muscle tumors. These mesenchymal tumors, which includes smooth muscle tumors, leiomyoma, leiomyosarcoma, inflammatory myofibroblastic tumors, or IMT, solitary fibrous tumor, rhabdomyosarcoma, and other mesenchymal tumors. And secondary lesions involving the prostate are GIST and other mesenchymal tumors. So this is the approach that I find very helpful. So when you see a spindle cell lesion, you have to exclude stromal hyperplasia first. So you have to ask yourself, if these bland spindle cells, do these bland spindle cell lesion have prominent blood vessels, multinodularity, and distinct cell borders? If your answer is yes, you're probably looking at a stromal hyperplasia or a BPH. If not, then you start to look at the cytological features, and you have to decide whether it's bland or it's atypical. In this case, it's atypical. And then you have to decide whether it's what kind of atypia it is. Is it degenerative atypia? There is no mitosis, no atypical mitosis, and no necrosis. And if there, it's just degenerative atypia, like the kind of you see in like the seminal vesicle or the ejaculatory duct, you're probably dealing with a stump. If there are frank atypia, there's increased mitoses, there are atypical mitoses, there is necrosis, then you're looking at something malignant, and you have to ask yourself if the patient has any history or concomitant prostate cancer. You might have to do some epithelial markers or prostatic markers, and if there's a history or if there's prostate cancer or the markers are positive for epithelial and prostatic markers, and you're probably looking at a sarcomatoid prostate cancer. But if not, then it's probably a prostatic stromal sarcoma or other sarcomas. Okay, now look at some, if it's a bland spindle cell lesions, then you have to ask yourself, are there any admixed benign glands? If yes, then it's probably a stump. If not, then you have to consider, it could still be a stump, but you still have to consider other mesenchymal tumors. Stump can grow in between the glands, right? They grow in the stroma, so there can be admixed glands. But mesenchymal tumors, they tend to have an expansile growth. They just push away the glands. So you just have the spindle cell lesion dilating glands. And you can also use some morphological clues to guide you. Like if you see intersecting fascicles, then you might throw in an SMA. And if that's positive, then it's probably a leiomyoma. if you see fascicular growth with perionuclear vacuoles, and you might want to throw in some CD117 and DOP1, and that came back positive, then it's just you see cell culture appearance with inflammation and extravasated red blood cells. You would want to do an ALK1, and if that's positive, it will help you diagnose an INT. We see ropey collagen with STAT6 positivity, then it's an SFT. If it looks like schwannoma or a neurofibroma, you want to throw in S100. And if you see one of these patterns, hypercellularity, Phyllodes-like pattern, myxoid or round or epithelioid cells, it could be a pattern of stump. So you want to throw in CD34 and PR, right? So in this case, it's probably a stump. So we did some stains. We did CD34, which is positive. Desmin was positive. Vimentin was positive. STAT6 was negative. SMA was negative. A1A3 was negative. And Ki67 was like dead negative. So it's a stump. This is a stump. So let me talk, now you know how to approach a spindle cell lesion. And I'm going to tell you what a stump is. It is a mesenchymal tumor that arises from specialized prostatic stroma, and it has uncertain clinical behavior. And there are some related terminologies like atypical stromal hyperplasia with atypia, Phyllodes tumor, Phyllodes type atypical stromal hyperplasia, and cystic epithelial stromal tumor. None of these are recommended by the WHO Blue Book. And it can involve either the transition zone or the peripheral zone. Clinical laboratory and imaging findings are non-specific. Typically, the patient presents with lower urinary tract symptoms. And less commonly, they can present with an abnormal rectal exam, hematuria, hematospermia, rectal fullness, palpable rectal mass, and or elevated PSA, like in this case. It's like a rare tumor, accounting for less than 0.5% of RP and TERP specimen. The median age is 57.5 years, but the range is wide, so it can be as young as 25 or as old as in their 80s. But typically, the patient is older than patients that has a prostatic stromal sarcoma. There's no known etiology and also no known risk factors. And it's probably a distinct type of tumor because studies have demonstrated recurrent losses of chromosomes 13, 14, 1p. So it's probably not just an ugly looking BPH. Grossly, they're whitish tan. They can be solid, or it can be solid or partially solid cystic, and they have smooth wall cysts filled with bloody, mucinous, or clear fluid, and the size can range from very small, like microscopic, and you incidentally found it, or it can be as large as like 15 centimeters. And under the microscope, it can have one or a combination of the following 5 patterns. The most common pattern would be the stromal cell with degenerative atypia, like in the case that I just showed you. And the other 4 patterns are hypercellular stroma with bland stromal cells, Phyllodes-like pattern, myxoid stroma, and the most recently described pattern is the epithelial or round cell pattern. So here is what they look like. This is the atypical cell with degenerative atypia pattern. This is the hypercellular pattern. This is the Phyllodes pattern. This is the myxoid pattern, and this is the round cell or the epithelioid pattern. And as you know, they can have admixed glands, and these admixed glands are benign glands, but they can show like crowding, complexity, as well as proliferative changes like adenosis, squamous urothelial metaplasia, basal cell hyperplasia, clear cell fibroform hyperplasia, and even high-grade Penh. And if you want to do some stains, I recommend doing the stains. It's not a tumor that we see every day. CD34 is typically positive. PR is typically positive. And they're variably positive for ER, SMA, Desmin, and STAT6, c-KIT, ALK1, and myogeny are typically negative. And you can use this table to help you diagnose stump. And About the prognosis, most are not aggressive, but the clinical behavior can be unpredictable because there are no, we don't have a good way um, of telling the prognosis because the histologic patterns do not correlate well with the clinical behavior or the presence of a concurrent prostatic stromal sarcoma. They tend to recur. They can recur after resection in about 15% of the cases, and they do that quite frequently and rapidly if the excision is incomplete. And there are two studies that show that 14% and 21.7% of cases can coexist with a prostatic stromal sarcoma. And a stump may also progress or dedifferentiate to prostatic stromal sarcoma. And that's it. I'm going to give you some follow-up information. The patient, after he got a biopsy, the urologist did a bone scan and found some lesion in his ribs, and the radiologist wasn't sure if it's met or it's just benign bone. So he didn't do anything yet, so just prescribed antibiotics. And then he ordered an MRI. An MRI showed no cancer, but the prostate was pretty large. It was over 100 milliliter. And they found like a BPH with some atypical features, but still like a Pyrex 2. And there was like a 5 centimeter abscess. So the urologist decided to treat prostatic abscess, so prescribed the patient antibiotics for the abscess. And the PSA continued to rise and peaking at almost 200. And the patient, the urologist did another biopsy from the right lobe. But the patient had a syncope, so I didn't do it from the left lobe. So that's to stop. So this is what the second biopsy showed. Pretty similar, I think. There are 4 pores, and you can probably see now that there are atypical cells in the stroma. They kind of stand out. Right. So on a higher magnification, these are like the atypical cells with degenerative atypia. Right. So we did another round of immunostains, and the results just came back essentially identical. This time we added like a progesterone receptor, and it's positive as well. And A1A3 was negative. Ki67 was like very few cells were positive. So it's still a stump. And the patient came back for a follow-up, and after antibiotics, the PSA starts to decrease, and it's not about 30. I don't think it has anything to do with stump. It's probably improving because of the abscess. And it's going to come for follow-up in a few weeks, I think. So that's my last slide. And these are my references. That's it. Be happy to take any questions.
Thank you so much, Dr. Nick. I think we have one question right now. Any comments on the differential diagnosis of bizarre stromal cells similar to what we see in the breast? It appears that arriving at the diagnosis is unavoidably immunostain dependent.
Differential diagnosis of bizarre stromal cells similar to what appears that arriving at IHC dependent. Yeah, I think I think I don't see breast lesions very often, but in the prostate, I think yeah, I probably do some stains to confirm the diagnosis. Maybe just a little bit of panel of stains if you. Jeff, do you think do you have ever diagnosed like
Stump?
stump?
Yeah, I was just about to tell you about it. Your patient is lucky because our patient unfortunately underwent surgery and he was like in his 30s wanting to have children. So it hit because it was too extended. They thought it was cancer and they hit the seminal vesicles. So your lecture is pretty good and to remind us that in relation to the first question that sometimes you do have to unavoidably do stains, especially you have those type of cells. I would still try to rule out prostate cancer, when they're too pleomorphic. I would do CT at the very least, which you did. And then, of course, as you said, if all the other stains are Bach negative for any carcinoma, I would tend to favor a stump, especially if you don't have necrosis or any unusual mitoactivity. I totally agree with you.
How does Dr. Epstein do it? Have you
It's the same reminder that you were saying. You try not to mentally forget about the stromal component because we're trained to always look at the epithelial component, right? As you said a while ago. So if you do find some atypia, my knee-jerk reaction will always be I'll try to rule out, of course, sarcoma. But if there's no other overriding feature, as you mentioned, I would also think of a stump as you showed in your differential algorithm. So stump I think the lecture here, if I may, should always remind people that stump is a possibility. It's not only for gynecological diagnoses. It is one of those that we have to consider when you're talking about atypia and the stromal component of the prostate.
Yeah, I think I had I experienced a psychological phenomenon that is called like inattentive blindness. If you're too focused on something, your brain is just too busy looking at the glance and you can't even see like something very obvious that's in front of you. What is the mechanism for PSA elevation in a stump or in the mesenchymal tumor? Can it be used for disease monitoring after resection? I don't know about that. I don't think the PSA has anything to do with the stump. Normally, it doesn't. I don't think it directly causes a PSA elevation. In my case, I think it's probably the abscess that was causing the elevation. Did we see abscess on the biopsy? No, we did not see an abscess on the biopsy. Just like atypical stromal cell. What's the etiology of the increasing PSA? Yeah, as I told you, I think it's probably the abscess. We didn't see any inflammation and probably I don't think they biopsy the area that was they were suspecting that an abscess.
If I may, Dr. Nick.
I'm sorry?
Just to add, I just want to add something regarding PSA. I think if I may, when you're talking about stromal lesions, you expect that most probably the PSA would be low. That would at least help you more in thinking that this is not epithelial. Of course, it's not an end-all be-all because some mesenchymal cancers can always have low PSA, but the discordance between those atypical cells with low PSA would make you think and lean towards more to a stump or stromal lesion. I think that was what Nick was also trying to say. Sorry to hijack it, Nick.
Did the clinical team do anything for the suspicious bone metastasis on bone scan? No, not that I'm aware of. I think it was just suspicious. I think they weren't really sure it's a bone met. There was still like differential diagnosis, benign bone in the clinical note.
We good? I think we're good. If I may, first and foremost, thank you so much, Dr. Nick, for presenting such a wonderful case. I think the importance of this is that it should be in our mind that it is a possibility. As you mentioned, most of the times we tend to forget the stromal component of the prostate, and we do have that bias that most of the lesions that we're supposed to be looking for are all epithelial. So I hope the audience learned a lot from Dr. Nick's lecture. And if you have any further questions, again, we would welcome them on the email. And we will try to post all of the answers via Dr. Nick's answers on the website. Thank you so much, Dr. Nick.
My pleasure.
We now proceed to our the CV of our next speaker, Dr. Adiluck. Please kindly show. The floor is yours, Dr. Adiluck.
Yes, thank you. Can you see my screen?
Yes, your screen's up now.
Okay. Are my slide moving?
Sorry, the slides are not yet shown. There, the first slide is up.
Okay. Okay, hello and welcome everyone. My name is Dr. Adiluck Pisutpunya from the Department of Pathology, Thammasat University, Thailand. It is truly an honor to be here today. I would like to sincerely thank SEAUPS for the kind invitation and the opportunity to present this interesting case at our first webinar conference. I have no financial or personal interest to disclose. Okay, let's start with my case. An 84-year-old man present with gross hematuria. The laboratory finding show a PSA level of 0.2 nanogram per milliliter. The normal range is 0 to 4. The cystoscopic examination revealed necrotic tissue along the prostatic urethra, and the bladder could not be evaluated due to the gross hematuria. Transrectal ultrasound guide biopsy was subsequently performed, or trace biopsy was performed. And these cystoscopic pictures show necrotic tissue along the prostatic urethra. You can see in these pictures. I got this case from my colleague. This is a trace biopsy from this patient. In the low magnification, the histologic examination of the prostate core revealed infiltration by the tumor cells arranged in tubercular and small nest pattern. The surrounding stroma exhibit desmoplastic reaction. You can see here. Some of the tumor nests resemble basal cell morphologically. Here is the tumor cell, and the morphology is resemble to the basal cell here. This is, I think, is very important clue to me. At higher magnification, the stromal shows desmoplastic reaction admixed with lymphocytic infiltrate and infiltrating tumor cell. Once again, you can see the tumor cell have a same morphologically to the basal cell here. The tumor cell exhibit nuclear pleomorphism, fine chromatin, prominent nucleoli, and scant amount of basophilic cytoplasm, and you can see mitotic figures here. The provisional diagnosis was positive for carcinoma involving all 12 cores in both sides of prostates, and we gave the differential diagnosis include urothelial carcinoma since the patient had a history of hematuria. The second one is high-grade prostatic adenocarcinoma, and the last one is adenocystic carcinoma of the prostate, or basal cell carcinoma of the prostate. And comments about the immunohistochemical study, including CK7, GATA3, P63, NKX3.1, BCL2, and Ki67 are pending for further workup. Here is an immunostain CK7 demonstrate diffuse positivity in the tumor cells. And also the BCL2 reveal diffuse positivity in the tumor cell as well. Interesting, P63 highlight the outermost layer of the tumor nest as shown here in the only the peripheral zone of the tumor cells. And GATA3 urothelial marker show a negative nuclear staining. The tumor is negative for NKX3.1, while the internal control show reactive staining here. This tumor are negative. The Ki67 is approximately 50 to 60%, reflecting a high proliferative index. So the final diagnosis is adenocystic or basal cell carcinoma of the prostate. Subsequently, the patient underwent further workup. The SHADE X-ray revealed multiple bilateral pulmonary nodules, along with a right side pleural effusion, as you can see here. A contrast-enhanced CT scan of the chest and whole abdomen was also performed for further workup. The findings include an enlarged prostate gland with diffuse heterogeneous enhancement measuring about 7 centimeters, multiple ill-defined hypodental lesions were noted in both liver lobes, favoring hepatic metastasis, as well with the bilateral lung nodules favor pulmonary metastasis, and a large volume of right pleural effusion was also observed. Due to the development of a right pleural effusion, the patient underwent right thoracocentesis for cytologic evaluation, and this is a smear slide from PAPS stain, reveal a few clusters of atypical large cell within a lymphoid background. This atypical cell exhibit nuclear pleomorphism, 5-chromatin, and prominent nucleoli resembling those observed in the prostate core. And the cell box preparation also demonstrate the tumor cell morphologically similar to those in the prostate tissue. The tumor cells show positive for BCL2 and are negative for INSM1, a neuroendocrine marker. These findings are consistent with metastatic adenoid carcinoma of the prostate to the lung, and the patient had a malignant pleural effusion. Unfortunately, the patient passed away 1 month after the diagnosis was made. So I would like to provide a brief overview about adenoid cystic carcinoma of the prostate. According to the WHO Blue Book, adenoid cystic carcinoma is classified under squamous neoplasm of prostate. This tumor is a malignant neoplasm originating from prostatic basal cells. Patients commonly present with urinary obstruction. The diagnosis is most frequently made on the transurethral resection specimen or TURP, and less commonly on the needle biopsy as at this case. Notably, serum PSA levels are typically within normal range unless there is a concomitant acina adenocarcinoma, which occur in a minority of cases, as observed in our case where the PSA level was within the normal limit. There are 2 histologic patterns of this tumor. First is the adenocystic or cribriform pattern with inspisate secretion in the lumens, and the second is the basaloid pattern consisting of small cell nest of the basal cell, as this case. It is important to distinguish this tumor from basal cell hyperplasia, which is benign. So there are 5 criteria as follows. The first one is the cytoarchitectural atypia and invasive pattern into the stroma and between normal prostate acini, or you can see the desmoplasia in the stroma. Perineural invasion, necrosis in some cases, in few cases, and extraprostatic extension. Moving on to the immunohistochemical finding, basal cell marker typically highlight the outermost layer of the tumor nest in basal cell carcinoma, while sparing the luminal cell. In our case, P63 staining demonstrate this classic pattern, strongly labeling the outermost layer of the tumor nest. Next is CK7, show positive staining in the luminal cells. BCL2 is strongly positive, which is a characteristic feature of adenoid cystic carcinoma. Ki67 proliferation index is high, helping to distinguish this malignancy from basal cell hyperplasia, which generally show low Ki67. Additionally, this tumor is negative to weakly positive for AMACR or racemase and androgen receptor. Molecular testing can help confirm the diagnosis in some difficult cases. About 17 to 47% of adenoid cystic carcinoma of the prostate show a MIB NFIB gene fusion, like in the salivary gland in the lung as well. This fusion is not found in benign basal cell hyperplasia. Also, TMPRSS2 ERG fusion gene, which are common in typical prostate cancer, are not seen in this entity. Several important differential diagnoses should be considered, including urothelial carcinoma, high-grade acina adenocarcinoma, neuroendocrine carcinoma, or metastatic adenoid cystic carcinoma from primary area, including the Cowper gland. In terms of prognosis, extraprostatic extension of this tumor has been reported in approximately 44 to 71% of cases in the radical prostatectomy specimen. Distant metastasis occur in about 14 to 29% of patients, and half of those with metastasis die from the disease. This finding support that this tumor is a potentially aggressive neoplasm. Therefore, it often requires definitive or ablative treatment. Okay, that's all of my case. Thank you all for your attention. I would like to express my sincere gratitude to Professor Epstein for his excellent lecture and to SEAUPS for the opportunity to share this case with you today. Thank you.
Thank you so much, Dr. Adiluck. Maybe a question while others are composing their questions. This is such a rare case that I personally can possibly miss. What made you think and suspect initially that a basal cell carcinoma is a possibility, considering the first thing, as you mentioned, that I would think of would be lesion 10 cancer or urothelial carcinoma, especially with the hematuria?
In this case, the important clue to me is the tumor cell infiltrating along the core of prostate, all cores, and the histomorphology have similar to the basal cell, adjacent basal cell. Yeah, that is important thing, and I think we have to exclude the other possibility common tumor around here, such as urothelial carcinoma or high-grade adenocarcinoma of prostate.
Out of your, oh, sorry, there's a question here. Without immunohistochemical stain, my consideration favors urothelial carcinoma, as we mentioned. Will this change the treatment outcome?
To be honest, I'm not sure about the treatment outcome, but I think that the adenocystic carcinoma of prostate is an aggressive tumor. As this case, the patient has several metastases, is poor prognosis, and he passed away after the diagnosis month. But if it is urothelial carcinoma, there is a definite treatment for the urothelial carcinoma, as we know.
I think to answer that, based on my experience, Dr. Riolo, I agree with Dr. Adiluck. This is a very aggressive tumor, and oftentimes there's still a question as to what the proper treatment would be for this tumor. Most of the time, it would be usually surgery, but it often fails, as Dr. Adiluck mentioned, because that's the patient died, right, Dr. Adiluck?
Yes.
Any other question? Okay, I think that's it. If we have any other questions, again, we will welcome them to the email and we will post the answers on our website. Again, congratulations, Dr. Adiluck, on a great lecture. Before closing, may I request participants as a favor for the SEAUPS, please fill the feedback form. And may I call now the Vice President of the Society, Dr. Anglita from Indonesia, for the closing remarks.
Thank you, Dr. Jeffrey. And hello, everyone. Good evening, very good morning, and thank you for being with us until this late. It's in some hemisphere of our world. So really highest appreciation and gratitude also to all our distinguished speakers, Dr. Epstein, Dr. Nick, and also Dr. Adiluck. Thank you so much. I do believe that all the participants tonight really learned a lot from all of you. Thank you. And also for all the SEAUPS founders, thank you so much, especially our dear President, Dr. Jeffrey. So thank you. Really happy having all of you together in this society. And also highly appreciation to the educational committee. All the team did a very well works and job. Thank you so much. Really love you all. And then also for all the participants who attending this first webinar from the SEAUPS, thank you so much. Highly appreciation. Really, your coming is very meaningful and valuable support to us as our new society looks very welcome for everybody. So keep with us. I would like also to remind you and inform you that we will have another webinar series on August with also a very distinguished guest, Dr. Gladel Panner, will give some lectures about uropathology also. And maybe this is also a good news that we are pleased to have almost or more than 600 registrants for the meeting, this Zoom. And eventually, until now, we have almost 250 viewers and participants that can join with our Zoom. Thank you so much for being with us. I do believe that some of you already very late and some of you still in the morning. Some welcoming also came from Peru. Thank you so much for the participation, and hopefully can meet you again in our next webinar on August. And please become our member because our next webinar will be for members. Thank you so much and hopefully can see you. Thank you for all the SEAUPS member. Have a very good night and also have a very nice weekend. Bye.
Thank you so
Thank you
much.
to everybody. Good night. Thank you.